many of our activities of daily living have us internally rotated at the glenohumeral joint. You know, here we've highlighted the desk jockey, if you will, but I think that we can include activities like driving a car, spending time on a stationary bike, or decompressing after a hard day of work and wedging ourselves into the corner of a comfy couch and binge watching our favorite shows, all the while being internally rotated at the glenohumeral joint, okay? Some symptoms that would let us know our patient's having some problems with subscapularis: loss of shoulder motion, pain in the shoulder with overhead movement. That pain could be diffuse or it could be sharp. Difficulty or pain with reaching into the back pocket, tucking in a shirt. I was thinking, you know, reaching, handing, you know, if you're the driver of a mom van and you're reaching back, handing snacks into that back seat, that could create some pain or difficulty if you're having a subscapularis problem. Weakness or loss of shoulder stability, and then pain that's worse at night. All could be symptoms of a subscapularis problem. Here we're seeing a myofascial trigger point in subscapularis. This referred pain could actually be behind the scapula, posterior deltoid region, triceps, around the outside of an elbow, around the posterior aspect of the wrist. And so what we're looking at here is the X's represent where that myofascial trigger point might be located, and then the red where the patient may experience pain or discomfort. We have 4
in your palm. We get binding of the different layers of tissue. The skin, the superficial and deep layers of fascia, and the muscles all bind together. And that serves a couple of purposes. It helps to protect the neurovascular structures, both in the bottom of your foot as well as in your palm. But in your foot specifically, the way that the pennate muscles in the bottom of your feet attach to the fascia, well, that's what allows your feet to act like springs. And that's what allows us to bounce and jump and recoil. The way that we have that intimate relationship between the muscles in the foot into the fascia. And we're going to take advantage of that intimate relationship, both when we assess as well as when we treat. When we are treating the condition, we may need to pay special attention to those muscles to remove abusive load in the acute term, in the short term. But then in the long term, as we try to strengthen that fascia, it may help by strengthening the muscles as well that attach to that fascia. And so then talking about the different muscles in the feet, we have many foot intrinsic muscles. The ones we're going to pay specific attention to are the flexor digitorum brevis, abductor hallucis, and quadratus plantar, especially that medial head. But they're going to attach, or originate, I should say, right out that medial calcaneal tubercle, right along with that origin of the plantar fascia. So if that plantar fascia is irritated and inflamed, it may affect those muscles. But again, if we are trying to treat that insertion, we may want to be addressing those muscles as well, as they do attach in that same spot on that medial calcaneal tubercle. When we look at the innervation of the plantar aspect of the foot, it's primarily innervated by the tibial nerve. And so the tibial nerve is going to pass through the tarsal tunnel, analogous to the carpal tunnel in your wrist, but the tarsal tunnel is going to sit just posterior and inferior